This beating human heart is a living engine. Its continuous hydrodynamic motion makes it uniquely susceptible to microscopic sabotage, marked here by aggressive tissue inflammation. This heart wall cross-section reveals its architecture: the outer epicardium, the thick myocardium in the middle, and the ultra-thin inner endocardium. Zooming in, this continuous endocardial layer doesn't stop at the chamber walls. It folds completely over the delicate valve leaflets, protecting them. When microbes invade and inflame the specific inner lining, the condition is called infective endocarditis. The infection almost exclusively targets these specific valve leaflets. Normally, an intact endocardial lining is slick. The constant, rapid flow of blood washes away debris, making it incredibly difficult for circulating bacteria to attach. Yet, a routine dental cleaning or a minor skin laceration can introduce flora into the blood. In specific patients, those everyday bacteria bypass the heart's defenses and precipitate acute cardiac failure. Endocarditis is a mechanical compromise of the body's most critical hydrodynamic system. For a bacterial vegetation to form on a heart valve, two distinct events must occur in exact sequence. Clinicians call this the two-hit model. The first hit is structural. Turbulent blood flow or high pressure creates a microscopic tear in the valve's endothelial tissue. Looking at this microscopic view of a structural tear, you can see the body's misguided physiological repair sequence in action. Platelets and fibrin rapidly accumulate over the exposed collagen, forming a sticky web-like clot. This sterile fibrin platelet mesh is labeled non-bacterial thrombotic endocarditis, or NBTE. At this stage, the clot exists, but there is no infection. The second necessary hit is bacteremia, the transient presence of bacteria actively circulating in the bloodstream. Bacteria require an entry point. A routine epithelial breach, like an IV needle stick, a urinary catheter, or a dental tool scraping the gums, provides that exact access directly into the blood. In this fast-flowing fluid environment, watch as circulating bacteria discover the sterile NBTE mesh. They physically slam into the fibrous web, binding tightly, and rapidly colonize the structure. The sterile clot is now a microbial vegetation. A structural defect creates a microscopic landing pad, and a subsequent bloodstream invasion occupies it. Endocarditis requires this perfect biological storm. The speed and severity of endocarditis depend entirely on which specific bacterial species breaches the bloodstream. The acute presentation is a rapid, highly destructive disease. It is driven by extremely virulent pathogens like Staphylococcus aureus, a common skin bacteria. Staphylococcus aureus is an exception to the standard rule. It is so aggressive that it can bypass the two-hit model completely, directly attaching to and destroying healthy, uninjured valves in a matter of days. The subacute presentation is a slow, smoldering infection. It is driven by low-virulence pathogens like Streptococcus viridans, which naturally resides in the oral cavity. Because these subacute organisms are less aggressive, they strictly adhere to the two-hit model. They require previously damaged or scarred valves, like those affected by rheumatic fever or mitral valve prolapse, to take hold. Other pathogens have highly specialized correlations. Streptococcus epidermidis specifically targets prosthetic heart valves and artificial pacemakers. An infection by Streptococcus galliticus acts as a red flag for underlying colon cancer, prompting immediate gastrointestinal screening. Knowing the exact bacterial species dictates the choice of antibiotic and predicts the velocity of the patient's cardiovascular collapse. The physical location of the infected valve determines the downstream systemic consequences. In the general population, the left-sided valves, mitral and aortic, are the most frequent targets. The left side of the heart pumps blood to the entire body, meaning it operates under significantly higher systemic blood pressure. This higher pressure creates more turbulence, leading to more frequent endothelial microtears, supplying the first hit.
Intravenous drug users present a major demographic exception to this rule. This schematic traces the venous circulatory system following a path from a peripheral arm vein directly into the right side of the heart. Contaminated IV fluid travels directly into the right atrium. The bacteria crash immediately into the tricuspid valve, striking this area first before they ever reach the lungs. Because of this anatomical plumbing, IV drug users predominantly develop right-sided endocarditis on the tricuspid valve. The location of the infected valve dictates where the infection spreads. The left side pumps to the brain and the body, while the right side pumps directly to the lungs. The physical geography of the initial vegetation serves as a predictive map for which organ system will fail next. This large, irregular mass of bacteria and fibrin is incredibly fragile. The constant sheer force of rushing blood causes the vegetation to break apart, launching infected shrapnel, called septic emboli, into the fluid stream. Left-sided emboli shoot into the systemic circulation. They can travel up the carotid arteries to cause ischemic strokes in the brain, or lodge downstream to infarct the kidneys and spleen. Clinicians look for a specific constellation of peripheral symptoms to identify these: systemic microemboli and immune reactions. This layout maps those signs using the medical mnemonic Fromagene. F stands for fever, tracking the systemic immune response. R is for Roth spots, which are hemorrhagic lesions visible on the retina. O represents Osler nodes. These painful, raised lesions on the fingers and toes result from immune complex deposition. M is for murmur. The physical destruction of the valve leaflets creates a new or worsening regurgitation murmur as blood flows backward through the defective seal. J stands for Janeway lesions. These are flat, painless spots that appear on the palms and soles, caused by direct bacterial microclots lodging in the capillaries. The distinction is clinically critical. Osler nodes are an immune reaction, making them painful. Janeway lesions are direct infectious emboli, making them painless. Finally, A is for anemia of chronic disease, N is for nail bed or splinter hemorrhages, and E stands for major embolic events. An endocarditis infection originates as a localized cardiac lesion. Its primary clinical presentation manifests as a rapidly escalating multi-system collapse. Clinicians rely on a rigorous diagnostic framework called the Modified Duke criteria to confirm the disease. The first major diagnostic requirement is isolating the specific enemy. This is achieved by securing 2 separate positive blood cultures. The second major diagnostic requirement is visual confirmation of the vegetation or the resultant valve damage using an echocardiogram. This side-by-side acoustic pathway comparison demonstrates the imaging options. On the left, a standard surface ultrasound, or TTE, has its signal partially blocked by the ribs and lungs. On the right, a transesophageal echo provides a superior, unobstructed view of the valves because the probe images the heart directly from the adjacent esophagus. If the vegetation goes undetected, the bacteria eat into the surrounding heart muscle. This causes ring abscesses and fatal electrical conduction blocks. Once detected, the pharmacological protocol is grueling. The goal is total bacterial eradication. Because the vegetation lacks a direct blood supply, standard antibiotics cannot easily penetrate the mass. Eradication requires 4 to 6 weeks of continuous high-dose intravenous antibiotics. Pharmacological treatment has limits. When native valves are completely destroyed, or when massive abscesses form, open heart valve replacement surgery becomes mandatory. High-risk patients, such as those with prosthetic valves, are given prophylactic antibiotics right before dental procedures. This preemptively blocks the bacteremia, stopping the second hit before colonization can begin. Surviving endocarditis requires outpacing a relentless pathogen, detecting the invisible threat before it dismantles the heart.